Hi, everybody. My name's Allysa Saggese. I am a nurse practitioner at Weill Cornell Medicine in New York, and I have the pleasure of discussing the latest and greatest management of MASH today. Thank you, GHAPP and FocusMed, for having me here, and for this extremely well-timed discussion right after lunch. Just remember, calories don't count at GHAPP. These are my disclosures. I like starting off with the very, very basics of MASLD MASH, what it stands for, just so we're all on the same page. MASLD is metabolic dysfunction associated steatotic liver disease, which we used to call non-alcoholic fatty liver disease, and it is very simply fat in the liver. MASH is metabolic dysfunction associated steatohepatitis, as we used to call non-alcoholic steatohepatitis, and it is fat in the liver that is causing inflammation. This is also how I describe it to my patients so they understand. In November 2023, new nomenclature and organization was developed. We now classify a spectrum of steatotic liver disease. We have our MASLD MASH on the left there. MASH is a subsect of MASLD. It is the inflammatory type. Not all MASLD causes inflammation, but that is a characteristic of MASH. We now have a new term, MASLD, which is MASLD or MASH with some increased alcohol consumption, and that's its own spectrum. Under steatotic liver disease, we also have alcohol liver disease and some other rarer causes. Today, I will only be talking about MASLD MASH. In diagnosing MASLD MASH, in that new nomenclature and organization, there became more defined ways to get to the conclusion of diagnosing MASLD. So we start out with finding fat in the liver, as one would expect, whether by imaging or biopsy. You may have a patient come to you with elevated liver tests, do an ultrasound, and it says steatosis in the liver. You then next see if they have any of these cardiometabolic criteria in that blue box on the right. MASLD is defined by having at least one of these. And cardiometabolic criteria is exactly what you think it would be based on the name: high BMI, high blood pressure, high cholesterol, etc. So if they have one of these and they found fat on the liver somehow, you then assess alcohol intake, as they may actually have MASLD or alcoholic liver disease. Alcoholic liver disease will cause fat in the liver as well. If they do not have a high intake of alcohol, very little to none, then you're able to diagnose MASLD. Anyone without the cardiometabolic criteria may have one of those other causes of steatotic liver disease. In talking about steatotic liver disease, we have to remember it is part of a bigger picture. It's part of systemic metabolic disarray. Anyone with MASLD MASH should be checked for other comorbidities, and vice versa. Those who have type 2 diabetes or obesity have a higher risk of MASLD MASH. It's very strongly associated. I just defined it as having one of those cardiometabolic criteria. So therefore, patients are more at risk if they have one or the other. And so the whole picture should be assessed and considered when you're seeing these patients. I've heard it put that MASLD is the liver manifestation of metabolic disorders, just like diabetes might be the endocrine manifestation, and high cholesterol is the cardiac manifestation. So it is part of a bigger picture here. Our non-invasive tests are getting better and better, and they're becoming more commonplace to use in our diagnosis of MASLD and MASH. MASH specifically, historically, always needed a liver biopsy in order to diagnose it. However, now we can use non-invasive tests more often and more confidently to be able to diagnose MASH and not just MASLD. The starting point with most non-invasive tests are our FIB-4, but I do want to point out FIB-4 is just a math equation. It is lab values in a plug-and-chug equation, so anything that can affect labs can also affect the FIB-4. But it is a good starting point to get some idea if somebody is at risk for having any fibrosis. From there, you can do some more specific, more complex tests like the FibroSure or ELF. Those are a bit more specific to fibrosis in MASLD. And if you have access, doing imaging tests like FibroScan or elastographies is even better. They're more specific and more sensitive to this. So whatever you have access to, the more non-invasive tests you're able to do, the more confident you can be in your diagnosis. And in the end, no matter what, anyone with a metabolic condition should have a workup for MASLD. The why do we care? Because it's not isolated. This is a worldwide epidemic. About 30% of the world has MASLD, and of those, about 25% have MASH. So we do need to care. The way I describe it to my patients is like this. Fat doesn't belong in the liver. It's irritating to it. It causes inflammation. If that happens, it can cause damage. A lot of irritation and inflammation over time makes for a lot of damage over time. Cirrhosis is a lot of damage. And anyone with cirrhosis has a risk of liver cancer or liver failure. And so prevention is for everyone, and treatment is for anyone who has this. So we don't want our patients to get to the point of risking liver cancer or having a liver transplant. And now to the management as to how we can do that. So it starts with hard work. Our non-pharm is our foundation of MASLD MASH treatment. It is diet, it is exercise, it is weight management. Humans in general are disinclined to do hard work. And so this takes a lot of time and effort on both parts to try to get something to change and to help a person get somewhere that they can get to with the non-pharmacological interventions. Some guidelines that we can use. We have the CDC's recommendations, 150 minutes of moderate intensity exercise per week, about 30 minutes a day, 5 days a week, adding 2 days of strength training. That is 7 days a week of exercise, more or less. So that's more of an ideal goal, probably for most people, but it's still something to be able to talk about and have as some sort of guidance to talk about what a person should be doing for their activity. For diet, the NIH recommends limiting intake of fats, sugars, and increasing fiber. As for alcohol, I usually say it's both a toxin and a calorie, so none is best. But if you find me later, do as I say, not as I do. But to put it really simply, do something that gets your heart rate up most of the days of the week if you can, and eat mostly protein, fiber, and just very little of everything else. And so when I'm talking about anything to my patients, but specifically these non-pharm plans, I think very hard about how I'm saying these things to my patients. I try to be as simple as I can, just break it down to as simple as I can, short sentences, something that they can remember. And I think a lot about the word choices I'm using. So verbiage is always on my mind. If you noticed, I said weight management, not weight loss. It is a management. We're doing that together. That's a collaborative word and association rather than weight loss, which is saying you do this. And weight is not linear, so it's always going to be management. I also usually say activity instead of exercise, because when I say exercise, the very first thing that comes out of the patient's mouth next is usually the gym. I haven't gotten to the gym. I want to go to the gym. I signed up for the gym. I don't actually mean the gym. That's a place. I mean, what activity are you doing? What things are you doing to make yourself feel stronger or get your heart rate up? So I think a lot about this when I'm talking to someone, because if anyone was in the obesity boot camp yesterday, one of the things that was said, which struck me as something that I think about too, is that our words can create bridges or barriers. And so I want to make a bridge. I want to make something that's accessible and doesn't feel like some sort of immediate barrier for the patient. Some patients like resources. Knowing what apps to recommend is great. Something like Couch to 5K or a diet app, a diet intake mapping kind of app. Whatever you might know yourself or have heard of is good to recommend. Media content, I like to vet certain potential maybe Instagram influencers or YouTube channels that I've watched and that align with what I say, and then I feel comfortable recommending them. Some patients might take to that better. And printouts are always good. Walking away with something in your hand is useful for a lot of people. For anyone who's really good at or knows in motivational interviewing well, I take some parts from it, but this is a really good method to use too. I might say, what are you thinking about changing next after we've discussed their diet or current activity? And it gets them to help be a part of the plan. Past accomplishments is part of motivational interviewing. So praising anything they've done before, reminding them that they did it once, they can do it again. Praising current accomplishments is really important. Some patients like to talk about details, so I might spend a few minutes picking one thing out. Maybe it was their breakfast. Maybe they said I have a piece of toast every morning. I might talk about what breads to change, what to add to it. That sometimes is just enough for them to walk away with a new idea and maybe some one new thing to change. Because when you talk about big picture, we want to talk about feeling better and getting stronger. That helps also just frame it for a patient too. And I like to get that in their head. The CDC's website does literally say something is better than nothing. And I'm glad because I say that all the time because small changes add up. So I say all of these things to a patient to help them grasp the bigger picture and to maybe just walk away with that feeling. And that might help feel more motivating. No matter what, all of this is about meeting the patient where they are in their journey. As for our pharmacological treatments, now we have things to offer. We had a very exciting year last year and into this one. We had our very, very first liver MASH treatment approved. So we now have resmetirom. It is first in class, and it was approved in March 2024. It is approved for MASH F2 to 3 fibrosis only. You actually do not need a liver biopsy to prescribe it. You can diagnose your MASH based on your NITs, as I discussed, which is great. It is a thyroid hormone receptor beta agonist, which is a mouthful, so you can say a THR-β. It basically helps fat get out of the liver, and it works on fibrosis too. So it is given as 60, 80, or 100 milligram tablets. It is weight-based dosing. You will be giving 80 or 100 to start, 60s for certain circumstances. It's easy. It's once a day with or without food. It does interact with high-dose statins, so you do have to lower before starting. All of that's in the package insert. During trials, resmetirom met its endpoints after 1 year. So that's the current guidance, is to check again after a year to see how a patient's doing on it. But obviously, you definitely should check again sooner if you feel inclined to and make that sort of plan with your patient. Trials, almost all MASH trials have these same endpoints. Specifically for resmetirom, the endpoints were resolution of MASH without worsening of fibrosis or with improvement of fibrosis. And of course, it should be used in conjunction with the healthy lifestyle changes. That's the foundation of all MASH treatments. The most common side effects are the most common side effects of almost anything: upset stomach, nausea, diarrhea. For most, those go away in a couple weeks. Some get nothing. Some might go on a little bit longer. No matter what, the most important thing is to discuss this with the patient before they start so they know what to expect, and you might have a plan in place. That would help them also stay on the medicine if they feel supported in that way and know what to expect. And our second very exciting thing was just a few weeks ago, really. Semaglutide just got approved for MASH F2 to 3 as well. It's a more indirect liver treatment. It is a glucagon-like peptide-1 receptor agonist, or as we more affectionately know it as, a GLP-1. And as we heard earlier, it works to help control blood sugars, weight. All of that's not liver-directed, but it does help the upstream, downstream effects of MASH and the metabolic comorbidities. And I know we went over this earlier too, but it comes in many doses. It's a once-weekly sub-Q injection. You're supposed to start at the lowest dose and titrate up to reach the maximum dose. The instructions are to increase every 4 weeks, but I do stretch it out longer depending on how the patient's tolerating it. And that, again, is a plan with the patient and a lot of discussion and communication and co-management of someone's medication with them. You can use the 1.7 milligram dose as maintenance dose, but you are supposed to try to re-challenge up to 2.4. And like I said, you can extend it 4 weeks, longer than 4 weeks as needed. In trials, semaglutide met its endpoints after 72 weeks at the 2.4 milligram dose, which is why that's the target dose. And again, its endpoints are the same: resolution of MASH without worsening of fibrosis or with improvement. And we all know the most common side effects really well: nausea, vomiting, diarrhea, or constipation. We know there's others too. Again, that's just discussing it ahead of time, making sure the person that you're treating is aware and have a plan in place as to what to do if this happens. Specifically, I want to remind everyone that those with a personal or family history of medullary thyroid cancer or MEN type 2 should not take this medication, so make sure you assess that ahead of time before prescribing. Otherwise, all other pharmacological treatments that may influence MASH are more about those cardiometabolic criteria and conditions, such as diabetes medications, statins, or other GLPs, GIPs, all of those. We are not afraid of statins in liver, by the way. They tend to help. They might make liver tests go up, but they also could come back down. It usually just takes monitoring and watching. And if you aren't a hepatology person, then being in touch with one to understand what to do if you think it is causing a drug-induced liver injury. So as we advance management, we most likely will be combining therapies. Resmetirom has very few medication interactions. It does interact with those statins, as I said, and some CYP substrates, all in the package inserts for any more specifics. During resmetirom trials, patients were on GLP-1 therapy. There did not seem to be a significant difference between those with diabetes on GLP-1 and those not, but either way, losing weight did help increase MASH resolution. So on the horizon, I always like these kinds of slides. I like seeing all of the potential drugs and targeted places that they can act on, and just being appreciative of the growing landscape and all of the potential for our future. And this was actually a picture from 2024. And so that bit on the right, we already have 2 things approved from there. It's super cool. So my miscellaneous is that about supplements and vitamins, I don't really like them. I really don't like detoxes. Don't even talk to me about them. Milk thistle, we have some research behind it. It might help, it may not, but it doesn't seem to do any harm. So if patients come to me on it, I don't really do anything about it, but I don't usually recommend it. Otherwise, I tell people just to stick to the normal stuff: multivitamin, the lettered vitamins, so to speak, and anything you're deficient in, like iron, magnesium, calcium, etc. And I always like to throw in there, regular coffee does have some liver protective effects, black coffee. So anyone who's drinking it, I tell them that's a good thing, keep doing that. I don't tell anyone who doesn't drink it to drink it, but it's a nice thing to have one positive thing to tell them out of all the things that they could possibly ask for that aren't pharmacological. So in summary, steatotic liver disease encompasses MASLD, MASH, alcoholic liver disease, and the combo, as well as other less common types. Diet, exercise, and weight management are the foundation of treatment now and forever. Engaging your patient in lifestyle modification takes time and effort on both parts. Resmetirom and semaglutide are the only approved medications to treat MASH F2 to 3. There are none for cirrhosis as of now. Other medications can indirectly help: our diabetes medications, statins, etc., anything that's taking care of cardiometabolic conditions. Supplements don't really help. And our future is likely these combos of therapies, additive, adjuvant, combination, and just hopefully more and more approvals come out of all of this. And I have my obligatory joke slide because this is how I feel patients feel. I really understand that too. I usually identify with that. And I thank you all for listening, and we'll take questions at the end.